Welcome from CVI2017. I'm Dr. Michael Luna here with Dr. Patrick McNair, who will be talking about aortic paravalvular leak closure. Welcome.
Thank you very much for having me. Let's see, so we'll go ahead and start off with the clinical scenario. So a 90-year-old woman with recent sapien S3 TAVR 3 months ago at an outside hospital, complicated by a moderate paravalvular leak, presents to her outpatient cardiologist with worsening shortness of breath, dyspnea on exertion, hypoxemia, essentially heart failure type symptoms, ongoing for the past couple weeks and progressive. There she was noted to be an atrial flutter. She underwent cardioversion into sinus rhythm. However, she was admitted to an outside hospital the next day to persistent symptoms as well as hypoxemia. She was started milrinone, given IV diuresis. She underwent a thoracentesis. However, this did not improve her respiratory status. And so at that time, transfer was initiated to our institution for further treatment of her heart failure as well as her paravalvular leak. And so as far as her past clinical history, of course, severe AS. The TAVR was actually complicated by hemopericardium as well as tamponade. She required pericardiocentesis. She had a complete heart block from the procedure as well, and so a single lead pacemaker was placed at that time. Kind of a prolonged hospitalization. She was in there for about a month, and it sounds like she did improve after the hospitalization. CAD, she had a stent right before the TAVR. Diastolic dysfunction, heart failure type symptoms. You can see the medications, aspirin, Plavix, carvedilol, Lipitor, and Advair. So when she first got to our institution, MAPs were in the mid-60s. She was paced around 70, 69, 70, to Kipnick with a respiratory rate at 28. Oxygen saturation in the high 80s on 8 liters of supplemental oxygen. She was tachypnic on her exam. She had elevated JVP. She had decreased breath sounds at the bases, and RALs going out the posterior lung fields about halfway up. +2 bilateral pitting lower extremity edema, and so she was certainly in heart failure with some respiratory distress. As far as the lab work when she first got there, hemoglobin was 7.4. At the outside hospital 2 days ago it was about 9.2, and so she did end up requiring a blood transfusion. Creatinine was up from 0.9 to 1.8 here at our hospital. BNP was elevated. Luckily, she did not have a lactic acidosis. ECG is just V-paced rhythm. She's sinus rhythm underlying, but there's complete AV dissociation consistent with her complete heart block. Chest X-ray, as you would expect, diffuse pulmonary edema. Right worse than the left. She did have that left-sided thoracentesis a couple days earlier. So as far as the echo at our institution, you can see in the left upper corner the peristernal long axis. You can see the eccentric aortic regurgitation consistent with the paravalvular leak. The bottom image is showing the 5-chamber view, and again, it's just very eccentric aortic regurgitation. The top right image, it's actually ice from the paravalvular leak closure, but I thought that this was a good representation about the eccentric nature of the paravalvular leak, and also gives you a good idea about the area involved as far as the leak. So she was diuresed, and she responded very well to diuresis. However, she was still very symptomatic, and she was still requiring a decent amount of oxygen. And so the paravalvular leak was closure was thought to be the best option for her. These are just a couple other Dopplers going over the paravalvular leak. So it's pressure half-time up on the left upper corner, around 300, and then she has diastolic flow reversal from the suprasternal notch. However, it was not holodiastolic. And so as far as the actual procedure, so first you can see the aortogram on the left-hand side. Going by Seller's criteria, it looks like it's about grade 2 aortic regurgitation. And so right femoral access was obtained, and the paravalvular leak was attempted to be crossed by retrograde approach. However, using several different catheters, weren't able to cross the leak. And so at this point, it was decided to go for an antegrade approach through a transapical approach. And so here is, under ultrasound guidance, a 4 French needle was placed, and then wire and a catheter was exchanged. And so the paravalvular leak was crossed with the wire, and you can see here that this was actually snared using the femoral access, so creating a rail system, an apical arterial rail system for stabilization while the paravalvular leak closure was performed. Next slide, you can actually see the implants or vascular plug 2 being pulled across the paravalvular leak. It's a 10 millimeter implants or vascular plug. Let's see, and then so as far as the finished result, you see the aortogram significantly reduced aortic regurgitation, and you can actually see the vascular plug in there right beside the TAVR. For repeat TTE, the parasternal long axis image on the left showing greatly decreased aortic regurgitation, as well as the short axis image on the right. She did very well after the procedure. She remained in our hospital for about another week undergoing diuresis, and she was discharged with just a little bit of supplemental oxygen. Checked recently, we haven't seen her in follow-up yet. Hopefully she'll be able to come back and still be doing well. Thank you very much for the case. I'd like to go ahead and thank Dr. Scott Lim and Dr. Michael Bergasso, who's involved with the case.
Great, that's a great case. I noticed you didn't have a diastolic murmur in your exam. I'm assuming she had one.
So it was a little difficult to, I don't think that I would have been able to appreciate a diastolic murmur for her. While you can see as far as the echo images and as far as the angiographic images, the paravalvular leak was moderate, but I don't think that would have been substantial enough where you might have heard a diastolic murmur. But
yeah, and sometimes the left ventricular and diastolic pressures are quite elevated, and that can affect the auscultation of a murmur or the existence of a murmur because of the filling pressure elevation. Another important thing, we do. In our field, a lot of these sorts of more complex interventions, but it's also important to make sure that we're not missing other things. And so I think a good thing to do here is to get a left ventricular diastolic pressures, and then compare that before and after plug implantation, so that you get an idea of if that volume node has affected the pressure.
I think that's a very excellent point. I think that. Unfortunately, I don't have exactly what the LVEDP was beforehand. I don't know if they measured it afterwards, but I think that's an excellent point. You can actually see whether or not there was a difference after closing the leak.
Right, exactly. Especially in cases where there are moderate lesions, and it's possible that it's something else that's causing the symptoms in the patient. It helps to rule out with more objective data. And now, how did you all handle the apex after exiting?
Yeah, so it was a single stitch. It was a purse string stitch, actually, that was placed. As far as the apical, the incision there, I'm not entirely sure exactly all the technical details of that, but it's a very good question. But right there at the skin, it was just close.
And the surgeon, I'm assuming, comes in and helps out with this transapical approach?
I believe so. Yeah, I believe so.
Great, thank you so much. That's a great case. All right, signing off from CVI 2017.